So we need diagnostics, we need drugs, we need control measures, and now we have not one but 2 vaccines. The vaccine doesn't work particularly well, but the best thing it's done is shown that we can do it, that you can deliver a vaccine against a very complicated parasite. And so now the floodgates have opened, and there's a lot that we can do in this space. The other thing I'd like to touch on is the fact that climate change is driving a lot of diseases, not just having an impact on malaria. It's very complex. We don't know exactly what it's doing, how it's impacting. We know it's driving things in terms of dengue in South America and also in Europe. We know it's having an impact through data that we see from places like Pakistan. But there are still significant gaps. So what we do need is innovative tools. We need innovative tools. We need to be thinking quite broadly about how we bring those tools to the primary health care, to the community health workers, and to the community. One of the things we'd really like to do is to engage with youth groups to make sure that any new tools that come on board have a real chance of being taken on board by being accepted by the community. So there's a real urgent need in terms of where we go forward, in terms of the type of innovation that we need. We need to try and think beyond the tools we have at the moment and how we might be able to use them in concert with the other tools that we have, drugs, vaccines, etc. And I think, neither one of them is going to do the job. We know that. There's some incredible drugs out there, but resistance is huge. In terms of control, there's resistance to the mosquito, is also got resistance to the impregnated nets. So in order for those to be able to deliver, in order to be able to deliver in an elimination setting, we need to really bring those 4 together so that they work in concert. I'm trying to keep track of my time because I do have a tendency to roll. So in that setting, we really do have an urgent need for true point of care, preferably molecular tools that we can engage in this setting. Because as the complexities of climate change roll on, the needs in each country is going to be very different. One thing I really should talk about when I talk about the needs is partnerships, and that's a big thing for FIND. We do all the work we do, and we're successful in the way that we are only because of the partnerships that we have, both in terms of the funders, but also in terms of our partners in country. And having a true understanding, a real understanding of what the needs are in country is what helps us to be able to deliver what we need to in the real world setting. So when it comes to elimination, I guess my talking points are really the need for a real advocacy in terms of climate change and the true world impact it has on everything that we're trying to do, and try and think of real ways that we can adapt and mitigate against what's coming. I think I'll pause there. Thank you, Elodie.
Thank you so much, Kevin, and really great to hear, that it's so important to understand what are the real needs coming from country, because I think this should really be the starting point for everything. And very much appreciate the focus on the impact that climate change may have on many different aspects, as you have just mentioned, in terms of not only from an epidemiological perspective, but also, such as very practical things in terms of, the temperature, the impact that increased temperature will have on the use of new diagnostic tools, for example, and obviously that's also the same for many other tools that we're using, drugs and etc. So very insightful comment. Thank you so much. Lucas, I'm going to turn over to you.
Yeah, thank you. Good afternoon, everybody. So, well, first of all, thank you for the organization, thank you for the panel. I think that I keep the line on trying to maintain the field reality, attached to the field reality. I think that I would like, as a MSF, to bring our experience of what we are seeing in the field, in the different settings that we are working. And what we are seeing is that malaria still is responsible for an acceptable high number of deaths, especially for a disease that is preventable and curable. I think that the high burden of the disease is in areas that people still challenged to have access to healthcare, and we are talking about very vulnerable populations. Has been said, a lot of tools, a lot of innovations has been developed in the recent year, from new drugs, vaccines, improvement in the testing, different prevention strategy. But I would like to insist, we would like to insist as an organization in the core message that no one single available malaria tool will be able to solve the malaria problem. The different tools need to be combined and implemented in, next to each other. And vaccination, as we were discussing this morning, is one part of them. From our field experience, all the tools and the available strategies are still far to be implemented in an optimal way. You know, so you can pick your example. But from vector control, for example, we see a very low coverage of mosquito net or indoor residual spraying. We see a lot of rupture of stock and the supply chains from diagnosis, rapid tests, and treatment. People still have challenging to access to blood banks and blood transfusion, especially in remote settings with IDP, refugee camps, these type of things. So that is remain a challenge. The preventive strategies are far to be implemented with the seasonal malaria chemoprophylaxis, the MDA, and all the prevention of malaria in pregnant women. But also we would like to share a good example because positive experiences are coming from the field as well, especially the one that we would like to share is the implementation of the Mass Drug Administration, MDA, as a rapid tool to a quickly reduction of malaria morbidity and mortality in emergency settings, as is recommended by WHO. So I want to contextualize this. In 2020, COVID, Ituri province in DRC, in Nangumu, so highly malaria endemic area, massive display of population, heavy rains at that time, that year, and well, and the MSF team in the ground, they were witnesses a high mortality rate due to the malaria, anemia, and other things. But in that complex, in that situation, in a complex humanitarian crisis, with population moving, with highly mortality, with limited access to healthcare, I think that in the midst of the COVID, you know, I think that the MDA was seeing a reasonable things to discuss with the aim to reduce mortality and morbidity, and especially in the short-term impact. So we did it. I think that following the WHO recommendation in different areas, 3 rounds of ACTs, 3-day course. The interesting thing is that the first 2 rounds were artesunate amodiaquine, but the last round was using the new drugs, the Piramax. So that was quite interesting. Huge preparation, very logistical preparation with was a door-to-door strategy at that time, so huge number of field teams with community health workers doing that. And we documented properly the coverage and the impact on the acute mortality rate and the mortality rate under 5. So the result was a very good coverage in the village, in the IDP camps, and a lot of adherence, and the people were quite happy about the Piramax in the way that they were not producing side effects, you know, so they were quite something to remark. And after that, we repeat the intervention in 2021 and 2022, and we noticed, you know, so that the reduction on the mortality. The second and the third round were combining with other measures, as we were discussing before, with the improvement and enhancing of the routine care and the use of indoor residual spray. And our conclusions are that the MDA is feasible to do it at a large scale. I think that we see the effect in the short term, especially in the under 5 mortality and morbidity. And when we combine with other tools, the effect on the malaria prevalence seems to be decreasing with combining with other tools. People will love it, and the report that we have is that people were loving to have a period of time without malaria. People can go to work, kids can go to school. You know, I think that there was something remarkable of the consequence of this intervention. And yes, it's a tool that is feasible to implement in complex humanitarian setting with high malaria burden. I think that can be part of the package of malaria control. We replicated the experience with all the lessons learned in South Sudan, in the north of South Sudan. I think that the next challenge is hopefully this year in Nangumu, we are also going to combine the malaria vaccine as well. So that's all.
Excellent. Thank you so much, Lucas. And really important, I think, to remind us all about, you know, this huge mortality that we are still facing today. I mean, 600,000 children dying every year is just frightening. I mean, for me, sometimes it's just difficult to realize that despite all those good tools that we have currently available, so many kids are still dying every day. And at the same time, it's still very positive to hear that, such practical strategy, which is 3 rounds of MDA, can actually decrease that mortality, and the success of your MDA and the high coverage that you have mentioned is very, I don't know, it's somehow reassuring. And also, I think that you have illustrated very well, the importance of combining all those different tools, because I think that we all agree that, one tool will never do the job. We definitely need to combine different interventions, different tools, and I think that you have really greatly show that, combining MDA, which is a new intervention, with, for example, indoor residual spraying can really make a huge difference, and is also very well accepted by the community, which is equally important. So both aspects are really fascinating to hear. So thank you so much. And with that, I would like to hand over to Noella. Thank you so much.
Thank you, Lodi. I would like first to appreciate this opportunity and the invitation that I got from the coordination team to come and share the experience of field specifically in relation to malaria elimination. I come from Tanzania. I'm going to share the experience of Tanzania, but not just Tanzania, but the entire sub-Saharan African countries. So I'm representing my brothers and sisters back home in Africa. So I'd like first to start by saying malaria is one of the luckiest diseases. And the reason why I'm saying it's one of the luckiest diseases is because it has received a lot of attraction from different partners, the experts, and different academia in terms of providing the technical how on how best is it to control and eliminate the disease in the continent. For a number of years, I would say we've had a stable finance in the countries, specifically the sub-Saharan African countries. We've had a stable stable funding capacity. And I would say at the beginning, we had a massive gains from that. But the past 8 to 10 years, with the same funding levels that we have had in the past, the situation is not really going down. We've had a plateau of burden of the malaria disease in our countries, and if you go down and dig into the data for every sub-Saharan African country, you would see that definitely there's either an increase of morbidity or increase of mortality. So what I'd like to say is getting on the reality on the ground specifically. The countries are doing a lot. They have great strategic plans. They have plans that are very creative, very much innovative plans, but unfortunately those plans are not funded, or the innovation has not been optimized to 100%. And this is mainly due to inadequate resources. When we talk about elimination, definitely it's not an easy task, especially when you're talking about elimination in African countries with very low low and medium socioeconomic income. Francesca, in the afternoon, in the morning, she mentioned that and some of the speakers, it's a disease of poverty, and poverty is there. So yes, we had at the beginning challenges of having treatments. We had at the beginning challenge of having the diagnostic tools and all that. Right now, that is no longer a challenge. Availability of commodities is good. The diagnostic tools is as well good. The only challenge that we are having is trying to venture on the new tool, implementation of the new tools, and to bring in innovation. So basically, I would like to say those are the main challenges that these countries we are facing. And the question that we need to ask ourselves is it worth investing a lot of money for a number of years without having significant gains? Is it high time to look and reflect back and see how best is it that we can, I understand the challenges of resources, but how best is it that such countries can be looked at in a different angle and see how best to reprogram and re-strategize our interventions so that all those that the countries feel and think they would bring malaria down should be supported. Unfortunately, they are not supported because either they are not in the appetite of the people who are currently providing the support, but also due to limited funding, and the priorities are going to commodities and treated nets and things like that. So those are a few, but I would like to as well agree to my previous panelists that climate change has been a great deal. We've experienced rains in periods when we are not supposed to be having rains. And we used to think malaria was a seasonality thing. But right now, really, that has not been the case from last year to date. We've had rains from last year up to just the past 2 to 3 weeks. That's when the rains stopped. So that means even the burden of disease tends to be increasing due to rainfalls. So I'd like to pause here and over to you. Thank you.
Thank you so much for such excellent comments. And I really hope that your sisters and brothers in Nigeria can hear you, because you're making such a vibrant plea, for sustainable financing. And I think that you have very well demonstrated that, if funding is coming, is even plateauing, which is currently the case in Nigeria, that is just not good enough. This is where we are really seeing an increase in mortality and morbidity, and it's just not acceptable. So. And that is, of course, having an impact on the implementation of the new tools that we are talking about. So thank you so much.
Thank you.
And I will now turn over to Petra. Thank you so much.
Thank you. Good afternoon. It's very difficult to be the last speaker after esteemed panelists and after lunch. So I'm hoping that I will bring some excitement into my intervention to get everybody listening to us. I'll start on a positive note. I know there's a lot of challenges and we highlighted them, and I'll come back to the challenges, but maybe some positive news here. In November of last year, 2023, we celebrated the distribution of 3 billion bed nets, which have resulted in the reduction of 2/3 of malaria infections. Distributing 3 billion bed nets is not an easy milestone, and it's not an easy task, and it has proved its effectiveness in reducing infections. The reason I bring this up, because as Red Cross, Red Crescent, we host this BedNet mapping project that has a lot of partners into it, and we consider this as an important milestone in the elimination of malaria globally. So I'll start with this one. And maybe a bit to frame what colleagues have just said. The way we have seen the challenge with malaria, we split it into 3 main things. We have the biological threats, we have non-biological threats, and then we have challenges with new tools. When it comes to biological threats, we're talking here drug resistance, we're talking resistance to insecticides, and we're talking challenges with surveillance. And on the resistance to insecticides, one of the solutions was dual active ingredients and bed nets. However, we need to be ahead of the game. The mosquitoes are adapting, and we do need to be ahead of that. When we talk about surveillance, surveillance has proven specifically community-based surveillance has proven its effectiveness in other diseases. It's still not very well utilized in vector-borne diseases, and specifically malaria. So that's on and then of course the drug resistance component there. That's on the biological. The non-biological threat, and going back to Kevin's point on the chair has 4 legs, we need someone to sit on the chair. If we don't get the communities to sit and utilize all of the legs of the chairs, we would not have an effective way of eliminating cholera. So the second non-biological challenge or threat revolves around communities. And what exactly we're talking here when we talk communities? We're talking we need to develop or expand or scale up community-level service delivery channels. When we talk about hard-to-reach, last-mile, conflict settings, fragile settings, we're talking about people and communities that do not come into the formal health system, have no reach to the formal health system. For us as Red Cross, Red Crescent, in many of these locations, we are the first and only contact for people for healthcare. And so developing these further is going to enhance our ability to make interventions for cholera and to distribute commodities. The second point on community, there is a community fatigue level with malaria prevention. And this is specifically relevant to low risk environments. We do see this on the BedNet side. We see that in low risk environments, there's a fatigue in utilizing malaria prevention interventions. And that's why we need to come up with different tools or different mechanisms, adapt our operational strategy. The last part related to communities is about the cross-border movement and the displacement. We talk about conflict, we talk about climate change, we talk about different crises. This is resulting in movement of people and displacement. When people move, the last thing they take with them is their preventive measures against malaria. And where they end up, in the communities they end up, they're not accounted for in the national plans for malaria. So these people are left out. They're left out where they land, and they don't take their preventive measures where they come and join the new communities. So that's on the non-biological threat. Now, the last one is the new tools. It's important we talk about behavioral change and acceptance of new tools when we're developing these new tools. We sit on many of the boards of innovations and developing tools, whether it is vaccine or drug or other preventive bed nets and all of that. Our feedback has always been engaging communities early on in the design, in the rollout, and in the follow-up is key for using these new tools. These tools are as effective as their ability to be accessed and utilized. So we can have the greatest tools. If they don't get to people, they're not gonna create the results that we're all aiming out of them. The last point here, we do have in the pipeline, the malaria vaccine is out there. We're talking now long-acting monoclonal antibodies. These are great solutions, and we're part of these solutions. However, national plans at the moment do not fit. And we spoke about, you mentioned the funding part. It's not, the operational national plans are not adapted to recognize and to consider these new tools within them. So there is a need to focus on how to integrate these tools and where to integrate them. We do need to have a stratified approach. And let's say when we talk about these communities that we have limited access to them, it might be the most useful, let's say, might be to use long-acting monoclonal antibodies to prevent them because we only have one-time access with them there. And one of the things that we're pushing is let's go in an integrated health package. Many of these communities would come when there is one of the health priorities for them. It might not be malaria, it might be something else. So if we create an integrated health service package, we would be checking off the box rather than in our siloed approach, disease-focused programs and donor-driven disease approach. Thank you.
Excellent remarks, Petra. I'm sure that everybody now is not sleeping anymore, if anybody was sleeping after lunch. And I mean, first of all, congratulations for such a great coverage with the BedNet. I mean, it's just super, really, very, very much impressive. So, and such an impact on the number of cases is truly impressive. And I also very much like your comments about the fact that community-based surveillance is not fully yet utilized in Malaria. And that's very interesting because we are talking a lot about new tools and new strategies such as MDA, but we also have lots of things to learn from other diseases and implement in practice in terms of health system strengthening and surveillance in particular. And I think that you made a very, you provide lots of great comments related to the need, of course, to involve community and the fact that it needs to be seated on that chair, and at least being one of the key pillars in the overall strategy that we are developing to address malaria. And that community fatigue level that is there, and that really needs to be overcome. Cross-border movement, you have mentioned that it's really something that we are experiencing everywhere. We are working a lot in South America, and I'm sure that Marcus can talk a lot about, cross-border issues as well. But, for example, in the Thai and Myanmar border, Colombia and Venezuela border, we are seeing that everywhere, and it's really something that needs to be addressed or taken into account. And then lastly, yes, new tools such as monoclonal antibodies, long-acting injectables are really very exciting future new tools, and I hope that we will be here in a few years' time to talk about that, and I really hope that we will have the opportunities to collaborate on that. MMB is very much involved in the development of long-acting injectable drugs, and we hope that in the next 5 years or so we will have those new tools coming coming to reality. So based on that really last comment about community, I would like to go back to that specific point to talk about the importance of involving local communities in our work. And I was wondering if any of you would have very concrete examples in terms of how you have seen this working and how and why is it so important. Yes, opening the floor. I don't know if Noela, Petra, or maybe Lucas would like to say a few words on that.
You want to go ahead? Go ahead.
Yeah, no. Okay, yeah, for example, indeed, I think that involving the communities and local communities is crucial. So from our side, from our experience, I think that we have this traditional approach that is involving the communities, empower them, and through the community health workers in order to, identify malaria, testing, treating, in order to decentralize care, to facilitate the access. But now we are discussing, as Dr. Petra was talking about, involving the community in the surveillance and how important, how game-changing this could be. But if I can say, maybe how the organization is reflected these days is we are trying to do the things in a different way, exactly in the line that Dr. Petra was talking about, involving the community in key decision-making process when we design a program, and at the moment to set up the foundation of a program, at the moment to monitor the program, or at the moment that we decide to leave, in which condition we are going to leave, and discuss with open and frank discussion with the community on that. And I think that involving patients and communities in these type of things could be a game changer in order to facilitate ownership for the new tools, the acceptance on these type of things, and create this accountability to manage their own disease. I think that we are in that reflection. It's not easy sometimes. It takes time. It's frustrating from both parties, I guess, sometimes. But I think that we are trying to have this change of mindset in the way that MSF is working in several settings.
It's good to hear. Yes, fully agree with, of course, the importance of involving community health workers, and because we all know that to reach malaria elimination, we'll have to involve community health workers. So there's no other way than doing that. And I really very much appreciate the importance of involving them in the decision-making process. Obviously, that makes lots of sense. There's a tendency to make a decision elsewhere, but they are the ones who are really, in charge of dealing with that disease. So, very much agree. Noela, maybe would you like to?
Yes, so I would like to add a little bit on what Lucas has just said. So basically on engaging the community, when we talk about elimination, the community members become key partners. So they are one amongst the main people that we need to partner with to ensure that we can eliminate malaria in our respective areas. And he mentioned that the community teams are used mostly in areas where we have high malaria burden to do the actual test and treat. But in Tanzania specifically, we are using the community people to actually do the identification of breeding habitats and treating these breeding habitats using larvicidin. At the same time, they also provide education to their fellow community members on how best to manage the environment in terms of modification and manipulation. So all that pertaining to, you know, clean up your area, make sure your drainages are not blocked and all that, that is the role that the community tends to do a lot. And it's this time that is with these interventions, the community test and treat, the lava source management, you cannot move away from engaging them. Mm-hmm. Otherwise, you're setting yourself to failure. So yes, community involvement is of highly importance. Thank you.
Thank you. Yeah, thank you so much for reminding us that, I mean, community health workers not only have an important in testing and treating, but obviously also in providing patient education. That's very, very critical to make sure that those new tools are well used. So thank you so much. I don't know, Petra, if you would like to add any additional comments.
Maybe I'll give some concrete examples on how communities mobilized. If we reflect a bit on COVID, the Red Crescent Channel has 16 million volunteers and 190,000 branches. In COVID, that network reached more than 1 billion people with COVID activities, and this ranges from immunization to prevention to hospitalization to care. Immunization on its own, we almost immunized 300 million people. That's an example how communities and community actors are able to mobilize and are able to influence a health emergency. Malaria has been for long with us, and it doesn't look like it's going away anytime soon. We really need to invest in our community systems. Another example I'll give, in 2022, in the midst of COVID, when everybody was investing in COVID, all the money was going to COVID, the financing, the BedNet project managed, despite everything, to distribute 190 million bed nets because of its community reach and its community network. And so these are examples of concrete outcomes where communities, when communities were at the heart, they managed to mobilize and make a difference in an outbreak. Thank you.
Thank you so much. Sorry, I'm becoming a bit thirsty. Thank you so much. All right, so moving on, I think related to that, obviously, we need to ensure that vulnerable populations are getting those new tools and intervention that we've been talking about. So maybe, Marcus, if you could give us some examples in terms of how this has been implemented and how can you address, I mean, how can you reach the enriched, basically, and where have you seen this working well in Brazil? Thank you.
Yeah, I have a good example for that. I think some of you will recognize yourselves in what I'm going to say. In one day, you receive like 50 emails, and usually what we do is that we answer the easiest ones, right? So you keep answering all the easy ones, and when you come to a very difficult email which will extract a lot of your attention, you say, well, I'm going to get a coffee, or I'm going to the restroom, right? And at the end of the day, from those 50 emails, you're left with 10 very difficult emails. Next day, 50 more, and you end up trying to do your pre-task, which is cleaning the easy ones. That leads at the end of the week to a lot of problems. You haven't solved the real problems. And in public health, I think that cleaning your inbox is what people are doing a lot. They start by the easy part of the job. So usually they have new tools. Those new tools, they are actually implemented in the good places with a good population. And then you lose timing, you lose in the momentum, you lose the funding. And that new tool usually does not reach those who most need it. In Brazil, when we have approved tafenoquine as a single-dose drug, which is amazing for someone to be treated with the anti-relapse drug using a single dose instead of 14 days or 7 days, in Brazil, we have decided to make the implementation in the Yanomami indigenous population. They were the first, because we assumed that if it was possible to do it there, it would be possible to do in the whole country. But not necessarily if that was possible to do in the big cities, we would reach them. So sometimes you have to do exactly the opposite as we have been told to do, because we are always losing momentum. When the eradication campaign started in Brazil, we all decided to eliminate malaria from the non-Amazon region. It was easy because there was the winter time, no transmission, you treat everybody. So we have eliminated malaria outside the Amazon. We lost all the funding, DDT, the vectors became resistant to DDT. So what happened? Malaria was restricted to the Amazon. So the Amazon was that tough email that nobody wanted to answer at the end of the day, and we are left with a huge problem at the end. So maybe sometimes thinking outside the box is just starting from the very difficult place and then moving to the other population who doesn't need it as much.
Thank you so much, Marcus. And I think that's analogy of dealing with the easy email first, of course, I think is is very relevant to all of us, I guess. And the importance, I think that's what the Brazilian MOH did in that specific instance, and going to the most remote place in the world, probably, or at least in the Amazon region, and really addressing the needs of those Yanomami population is just incredible, because it's really the most difficult place on earth where you would like to implement a new test and a new drug, and having to make sure that those patients will be followed up adequately. So that's really impressive. Thank you for that. Moving on, obviously we have been talking a lot about the positive experience that we have had so far. And we are all facing difficulties and encountering challenges when it is about when we are about to talk or to implement those new tools and those new strategies. So I would like also to ask our distinguished panelists, how have you been dealing with that, and how have you been overcoming those challenges, and if you have any practical example that you can provide on that. So maybe Kevin, would you like to say a word on that?
Sure. I think Marcus is feeding me my line. So if I can take the difficult email analogy, well, what we try to do, because we know where we're going to deploy these tools, right? So what we try and do is try and do the evaluations based in those countries. So we try and get as close to the problem as possible, and that's working with country partners. So one of the first things we have to, I skipped a bit, one of the first things we have to overcome is funding. So if you're coming in with a new tool or an innovative tool, you've got to try and advocate or really speak to the funders, the key stakeholders, to make sure that, because if they don't support it, you're not getting the money, right? But if you've got an idea, you still need to be able to try and somehow bring them along, convince them that this is going to work, and provide the necessary preliminary data. Some of it will be on models, etc. But the thing we try to do is, once we've got that money, sometimes we have harder data than models, we can then go into the country and try and think about how we get there. We're trying to be innovative in that space. So I guess one of the things I think I touched on earlier on was trying to engage with the community, but through youth groups as well. So we always try and make sure, we're primary healthcare. That's where we want to engage best, because we can do a lot of work and get a lot of successes in the primary healthcare. But to be able to get there, I think some of the things we need to do are improve the way that we engage with the communities. And one of the things we've been thinking about internally is, not only about getting new tools into the difficulties about getting new tools into the community, it's also about sensitizing that community by trying to get engagement early, by trying to make it clear what this will do, and try and keep the communities informed so they're part of the solution rather than just a piece of the puzzle, that they're part of that narrative. I'm not sure I entirely answered your question, but for us, that's kind of where we try and engage. Get new tools into an environment is always very difficult, and I think that evaluation piece is really clear. That's what I forgot. One of the things we always do going in with the new stuff is we try and we do a lot of landscapes, and those landscapes, so there's a device that we're trying to develop right now, and it is high tech, but PhD level engagement high tech. And so what we try and do is we talk to all the stakeholders. We talk from the community health workers, right through to the stakeholders in higher level healthcare infrastructure. Because what we want to do is get that full engagement. We want to get that full understanding so people know what it's going to do, how it feels, how it looks, what it's going to cost, what the impact's going to be. And so we get that engagement right from the beginning, and that information feeds back to us and from us to the developer so that we can think about how that tool will actually arrive in a way that the community is going to accept.
Yeah. Thank you so much. Thank you, Kevin, for this, for raising again the importance of working hand in hand with country partners. I really believe that it's really the best way to actually work to address malaria there, because I mean, if you do not have the buy-in, if you do not get strong engagement with key stakeholders, being at the community level or up to the national level, obviously that's pointless. So I fully agree with you. And then, Lucas, I don't know if you would like also to say a word on that. I mean, you have talked a lot about MDA, and I'm sure that has not always been an easy thing to implement, right? Especially in those very difficult contexts that you have mentioned. So,
yeah, I think that in the same line of Kevin was explaining, I think that at the community dimension, explaining a new intervention, especially, create a strong alliance, a strong partnership in order to have acceptance and ownership of that, was quite a challenge, especially because in the third round we were using a different drug, a new drug that the population were not used to, so that was a truly momentum to engage in. But I think that the team did a great job, because when you see the coverage of the different round up to 95%, so I think that was incredible. And then, much more from the organization perspective, the resources involved in the implementation of this new tool, so the mobilization of such amount, group of people from the logistic point of view, the almost 250 teams of community health workers going in the area, door to door, at that time was quite a challenging, the coordination. And worth to mention as well, the cost of the drugs and the availability of the drugs as well, because that was a challenge at that momentum. And I think that we learned a lot from the first round to the following rounds in how to try to adapt the intervention and do it much more cost effective. But yes, remain a huge challenge.
Yeah, thank you so much. And I think that both you and Kevin have highlighted that specific difficulties which is related to funding. And that sort of lead me to my last question before I turn to the audience for some specific question, which is partnership. And by partnership, I mean also in the financing space, obviously, but also in terms of research and implementation. And partnership is really a core value of the Geneva Health Forum, and for us as well, for many of us, we are really very much working in a partnership mode. And so I would like to really better understand what does that mean for you, and how can partnership help us to reach malaria elimination. So maybe I'm going to turn to Noela.
Thank you. So in terms of partnership, really, I would say it is a core area that is important when it comes to malaria elimination. And when we talk about partnership, we have to engage different sorts of partners from the beginning, when an intervention is being designed, implemented, and evidence is being generated. All the different sorts of partners have to come together. And when we talk about partnership, I'd like to mention a few that are key to be involved so that we can have successful malaria elimination in our countries. The first and foremost group or category that is important is the government itself. And that is political will and commitment from the government. The structures and the authorities that our governments have created in supporting the agenda of malaria elimination. The technical skills of people that they tend to put at different levels of the hierarchy, from the national level all the way to the village level. Because right now we are talking about community engagement. We have interventions that are being implemented at a very lower level. But then we have challenges with the village health workers. We have challenges with the village executive officers. They have no clue of any, health-related matters, including malaria. So that is important. In our districts, you would see that we do not have epidemiologists. We do not have entomologists. How then are we going to eliminate malaria? So the government really needs to audit the system. They need to make malaria a national agenda, audit the system to see that the structure and its authorities are supportive enough for us to be able to eliminate malaria. So you might have great interventions, but the people that you have to oversee or implement those interventions have some capacity issues. On the second is, on my opening remarks, I talk about the development partners. And I already mentioned, with elimination, definitely the funding envelope has to be improved. We cannot get there. It will not happen that easily. The funding envelope has to be increased. They have to get out of their comfort zone to fund stuff that currently are not of their appetite. So really, I would say, in that area, if we try and get out and start implementing other aspects, for example, in Tanzania, I would say we have managed to stratify the country very well in terms of burden of disease. And so we know exactly where is it that we have high burden, low burden, moderate, and very low. And we have tailored interventions based on those different stratas. The challenge is we do not have the funding to implement the tailored interventions. And those tailored interventions have been modeled. Some deep learning, techniques have been put in place to see what intervention will give us much more impact than the others. So if that ceiling would be increased, automatically we will get there. Then the other aspect is on the engagement now of multi-sectoral. Malaria, for so long, it has been the burden of just Ministry of Health. But the other sectors are the ones who are really increasing the burden of disease in our settings. We have the mining sector, constantly increasing breeding habitats, construction activities going on. We have huge excavations happening, and they are not, it just lives with very huge pots of breeding habitat when it rains. So we have to involve multi-sectoral so that they can themselves include malaria smart activities within their own sector and say, this is what we will do to eliminate malaria in our country as a sector. But then, that is also not very easy. Because when you talk about multi-sectoral, this is an initiative that in the country also have started implementing. They would think, oh, you're giving us money to help in implementing all those interventions. But actually, we want them to use their own resources and budget. So it has to be a parliamentarian agenda for them to push it forward. That every sector will need to know how much you have included in fight against malaria. They reinforce the laws are there, the acts are there, they just need to be reinforced. In their areas, they can definitely do a lot. There is this word that they usually say, corporate social responsibility, which in actual sense, it can be looked at in a very different angle. And the government, if they're willing and say, oh, in the next 5-10 years, our priority is malaria. All your social responsibility needs to go into malaria. Definitely, there would be change. Thank you.
Thank you so much, Noella, and really the need to, the importance of the governmental will and commitment and engagement to make that happen. Maybe I would like now to turn to the audience because time flies, and I want to make sure that we are addressing any questions that the audience may have. So I think we have a couple of microphones around, so please feel free to raise your hand and ask the question directly to the panelists. There's one here.
Thank you very much, Manuel from Swiss TPH. I'm really intrigued by how often it's mentioned that communities are important and communities need to be at the center of decision making, at the center of action, and I fully sympathize with that. But another aspect of that is that I strongly believe that the battle against malaria is going to be lost or won in the remote, underserved, rural, poor communities, in which not only patients but also the entire community are vulnerable. Now, how can we make sure that by putting communities, for example, through community health workers, in charge of their own health, in charge of providing sort of health promotion, in charge of health care, in charge of lots of different things, how can we make sure that this does not put actually additional burden on communities and community health workers that they have difficulty bearing? So in a way, you know, with good intentions, potentially not only good consequences. And the second part of the thought is that I quite strongly believe that most of us in this room, if our child was severely sick, we would expect our child to be seen by a specialized pediatrician. Are we happy and content if in rural, remote Africa a severely sick child is seen by a community health worker who got, you know, 2-3 weeks of training, or is that really not enough and we need to think much further? Thank you.
Thank you so much, Manuel. I think a really important question. I don't know if, Marcus, you're just coming back from that Yanomami land, and obviously the community health workers have been really important to be able to use the G6PD point of care, tafenoquine. Is it something that you could maybe talk to us a little bit more about?
I think that Manuel has a good point, and I think we can't make the confusion between what's technical advice and the aspiration to reach something. Whenever you go to the field and you talk about elimination, the only thing they absorb is that we're going to eliminate the disease with which they make money, so they're going to be fired. We have a lot of qualitative data showing that people who work only with malaria, and that's why Petra brought our attention to the fact that if you don't have One Health, people will feel that by the day there's no more malaria, they don't have their jobs. Actually, for many researchers, they don't know what to do if malaria is gone, because what they will do, they don't understand that their expertise could go to another disease, to help, to solve another problem. But definitely, most of these countries, they have lived for a long time under dictatorships. So they're actually waiting for someone to tell them what to do. And the change has to be, well, are you happy with your children being infected with malaria and not going to school and not learning and not having the access? So the community has to understand that, and that's the toughest part. And I agree with you that when we talk about community involvement, we're not doing that. We're actually giving them the right to decide what they want to do, but this technical advice has to come from a centralized way. There's no elimination if each municipality decides on what to do. There must be a technical advice, but they need to understand the rationale for eliminating that disease.
Maybe I can add a few things here, because we manage a large network of community health workers. Professional healthcare and community health workers are not either or. They're complementarity by nature. And the network of community health workers serve as a referral to the professional side. So yes, we want the children that get sick to receive the best and most professional care. But in many, many, many locations, the ones that you mentioned about, the remote and far to reach and hard to reach, displaced, migrants, refugees, camps, conflicts, that's not possible. And our role is to develop the skills of community health workers to be able early on intervene and then manage a referral and link it to the district level hospital and the national level hospital. So that's on the skill. On the burden on community health workers, if we do not develop the community health systems, we are adding an additional burden on community health workers. The question is, how do we develop this community health system? Financing it. The way this morning we had a panel that talks about maternal, child, newborn, and we had a diverse group of round table from all funders, donors, actors in that field. And the whole discussion revolved between donors and authorities. And then that's it. And then we were like, Okay, that's great. Donors like to speak to governments. But in many, many countries, the reality is governments do not have the totality of the population. They don't serve the totality of the population. We still have to bring a large portion of community actors to the table to access financing, the same way governments access financing, to develop community health systems and not put additional burden on the volunteers. We're a volunteer-based organization. I can tell you the burden there is huge because they're providing all sorts of services on a volunteer base. Great, it's mission-driven, but there's also the need to strengthen this so they remain in the communities before, during, and after disasters.
Thank you so much, Petra. Yeah. Kevin, you wanted to add?
Yeah, if I can just add, I think most of it's been said, but I just wanted to mention at COP28, this was a big discussion. There was a massive discussion about the importance of community health workers and how there should be more done to strengthen that group. And so there's more of a drive, where the money comes from I don't know, but there's more of a drive to expand that group because of its importance. I should also mention there's an organization called SEED set up by Vanessa Kerry, and that was really focused at being able to support and train community health workers, with the idea being just to address exactly what Petra said, to expand and take the pressure off, to really expand the pool of trained community health workers who can really engage and have the skills to be able to have that initial contact if you've got a long distance between the patient and the community health center. Okay.
Thank you so much. Thank you all. I think we still have a little bit of time for one or two additional questions.
Hello.
Yes.
Hello, my name is Hoon Sang Lee. I'm the Chief Strategy Officer at the Right Foundation in Korea. We fund research and development for health technology tool, such as vaccine diagnostic and therapeutics, and distress tool, and for LMIC. So if you've asked for like a funding space, I just wanted to let you know we are there available for your service. But I just wanted to make comments and ask some questions. So actually, one of the items actually we had been funding was G6PD deficiency malaria testing tool. And we had been really quite amazed by what Brazil had been really taking a charge to do national tafenoquine rollout together with the diagnostic tool options, along with the NBSA regulatory approval. I think it is opening door for such an approach for Latin America. But I have not seen such an effort in Asia or other regions. But I think one of the really important learned lesson in Brazil is how Brazil, as a whole of government, really work together between the regulatory body, also from academic side, with the trust study, have a really good evidence basis for the policy. And then the Ministry of Health really taking a charge for making national guideline and put into practice. But what would be take, how we can really expand or scale up the Brazil's country learned lesson to rest of the Latin America or globally, and how different continent or different country from different part of world can really collaborate together to really accelerate the process of scale up for this kind of new innovative approach. Thank you very much.
Thank you so much. I mean, it's great to hear those remarks. I mean, please don't move away at the end of the session. I'm sure that several of us will want to talk to you. I don't know if any of the panelists wants to make any comment or.
No, I just think there's a lot of fake news amongst researchers as well. So the first time we have been hearing about G6PD deficiency and how to test, people thought it was very much complicated. And when we went to the field and started telling people that it was like measuring glucose, it was not difficult at all. So I could easily take a full month to teach you how to read a thick blood smear here. But I, in 15 minutes, can tell you how to do G6PD testing. So a lot of people did not believe that those in the field were not able to do it, and it's very, very simple, very easy to do. A 5-minute video teaches anyone how to do G6PD testing. And I think the more and more you're going to start be using that, the countries will come to the conclusion that it's no big deal, and it's something that actually improves the primary care. So coming to your point, in Brazil nowadays, you have the access to G6PD testing in the riverine communities, but not in the hospitals. So we've changed those who are poor, they have access to G6PD deficiency, but not those who come to a reference hospital.
Thank you. And maybe just to add on that, I mean, just to add 1 minute of free publicity here, we, together with PATH and MME, have developed a partnership for vaccination called PAVE, and we are really very active in, especially Latin America, the Horn of Africa, and Southeast Asia, to really address the challenges related to Varvax malaria. And we are holding a regional meeting every year, one in Latin America. There was also one that was organized recently during May, but also during in the Southeast Asia region together with the APMEN Varvax Working Group. And we are really using those regional platforms to disseminate the evidence from studies like TRUST, for example, which are really bringing insightful new evidence on the real-world implementation of those new tools. And those results and those lessons learned are really shared with many different countries and at regional level to help and make sure that, you know, it is being used by other countries as well. And I very much agree with you that, you know, it is really important to make sure that the information is really flowing and making sure that everybody is aware of the latest evidence on that front. So thank you for your remark. Maybe we're going to take a very last question before I move to the concluding remark. Yes, Jonathan?
Hi, hello. Jonathan Novoa from MMV. The second topic of this Geneva Health Forum has been migration. It has been mentioned many times by Petra, and we are seeing, at least in the region where I work, and it's probably a very similar situation in other parts of the world, that there's a lot of people moving. Only this year, more than 120,000 people have crossed the Darien Gap, which is the border between Colombia and Venezuela, in their way to the north. And we believe that that area is where you have the highest risk for migrants to contract, to acquire malaria during their journey. So I wanted to know if you have thought or have also experiences dealing with migrant population, because it's not only a very vulnerable population, but a special one because they are one of the few vulnerable populations that do not actively seek on purpose healthcare because they want to walk and continue their journey. So they're really like shadows in the way. So I wanted to know, and we have seen also that has led to reestablishment of malaria, for instance, in Mexico bordering the USA. So I just wanted to know what experiences do you have, what recommendations do you foresee in strategies towards this special population?
Yeah,
Thanks.
excellent question. Thank you, Jonathan. Who wants to take it? Noela?
Yeah. So thank you for the question. It is true that there's significant movement in the areas that he has mentioned. It's not that just in those areas, but also even in Africa we're experiencing the same, especially in areas where we have borders. There's a lot of socioeconomic activities going on, and there are formal borders and non-formal borders. So there's a lot of interaction. And you definitely see that in those areas, malaria risk is very high. We've tried a number of times to moderate the situation, but it has been difficult. So the only way out on that definitely is cross-border collaboration. If you don't create initiatives of cross-border collaboration in such areas, it will not happen. And this takes 2 countries to collaborate, 3, 4, 5, 6, depending on how many borders, are in that specific area. So there definitely has to be some specific interventions implemented in those areas and some specific laws that would allow at least to first ensure that people are tested before they cross over. It's not easy, but definitely something can be done in that area. So yes, but I think it's a completely unique set of interventions that needs to be formulated specifically for the area with such characteristics. Thank you.
Maybe I can add
Yes,
something
please,
on the
Petra.
cross-border. Other than the cross-border, the way national malaria plans are set, they're set on an annual basis. There's no room for an operational adjustment. And when you see the movement of people at the middle of the year or at the end of the year, that requires operational adjustments. The funding, the way it comes you plan ahead of time and you go ahead with your national plan. That's a discussion with Global Fund and other main donors, is we do need to be agile and flexible in adjusting operational plan to acknowledge and support movement of people. The way we support them, we have a humanitarian service points, we call them, which provide health services. But commodities against malaria are usually through national plans. If they're not part of the national plans, access to these commodities become very difficult to provide them. So one of the things, other than the cross-border coordination, even if both borders coordinate, but there's no commodities and they're not fit in both plans, they're still not going to have access to interventions and commodities.
Thank you so much. Thank you. We are reaching the end of the session, and so as closing remarks, I would like to ask each of the panelists the very tricky, difficult question, which is what is it going to take to reach malaria elimination by 2030, and can we make it? So please say yes. Please, Marcus.
Yeah, eliminating malaria is definitely not like the bamboos flower in India. I was told once that all the bamboos in India, they flourish at the same time. And I'm not sure if each country will have the maturity to reach elimination at the same time, and they've got to be prepared for that. I think there is the timing for every country. Of course, starting by islands was the best and most efficient way to eliminate malaria. But now we left the tough email for the last, and I think that we have to be prepared for the timing of each country and each region.
Mm-hmm. Thank you. Kevin?
I think the answer was yes. And what is it going to take? It's going to take coordination. It's going to take money. I keep bouncing off of Marcus, but one of the things we're going to need to do is when you think about the country going in and how they're going to get there, if you think one country's about to achieve it, then the surrounding countries need to be on track, because if they're not, it's going to fail. So it's going to have to be a really coordinated cascade system that if a country's really close, then the effort goes into the surrounding countries to be able to deliver. So yes, but with some work.
Thank you.
Well, for me, at least from in the setting that MSF is working, it's going to be challenged to eliminate malaria. So I think that beside the coordination and the money that Kevin was mentioned, I think that we need to keep insisting in the key message of implementing properly the available tools. I think that reaching the unreachable populations, putting everybody on board on this, and of course keep investing in new things. So more cost-effective, rapid and accurate diagnosis tests, especially for the symptomatic, for example, addressing resistance that we were discussing before. I think that need to keep high in the agenda as well in order to at least try to control malaria.
Well, my answer would be yes and no. And I would say yes in areas where we have islands. That's definitely something that it can be done. For example, in Tanzania, we have Zanzibar, which has two islands, Pemba and Unguja. In Pemba, definitely we would say 2030 they'll be able to eliminate. But Unguja, still there are a lot of cases of upsurge. It goes down and then it rebounds back. And then in the mainland side, on the Tanzania mainland side, we are not going to get there by 2030, for sure, if we continue doing business as usual. But if we get out of business as usual, we will start that journey, but not actually eliminating by 2030. Thank you.
Thank you.
I did start on a positive note. I'm afraid I'm going to end it not on so positive note. I don't think we will be able to get to the targets by 2030. We have national malaria programs underfunded. We just spoke about how many community health workers we need. We have a shortage of 2 million on the African continent. The data speaks for itself. Unless we have a major change in trajectory on financing and on building systems, we're far from getting to the targets. Thank you.
With that, no, but thank you so much for the very rich and productive discussion. I really had this. I enjoyed it a lot. I learned a lot. So thank you so much for sharing your experience. It was really, really insightful. So I would like to applaud you all, and thank you so much to everyone for coming here today. Thank you.